My name is Dr. Desha, and the topic of the day is Urolithiasis and medical management. So we will see in this discussion about the definition, theories behind stone formation and composition, urinary ions, stone varieties, symptoms and signs, evaluation, prevention, history, risk factors, examination, radiologic investigation, and medical treatment. So first of all, definition. Urinary stones are basically composed of two components. One is the crystalloid component, and the other is the organic components. So urinary stones is a body, they are polycrystalline aggregates composed of varying amounts of crystalloid and organic matters found inside the urinary system, including kidney, urinary tract, and urethra. So supersaturation of urine depends on cyanic strength, urinary pH, solute concentration, and concentration. The crystal component of the stone is formed as nucleation, growth, and then aggregation. Nucleation is induced by proteinaceous matrix, crystals, bottom bodies, and other particular tissues. One type of crystal serves as a catalyst for the nucleation of another type of crystal with a similar structure. For example, uric acid crystals initiate calcium oxidation formation. Now, the other component of stone, which is the matrix component, which includes proteins, exons, and exosomes. The histology of which reveals lamination and scan calcifications and viscosity. Now, the theories behind stone formation include, first of all, the nucleation theory, which states that stones are formed by crystals or foreign bodies immersed in supersaturated urine. The other theory is crystal inhibitor theory, which says that these natural stone inhibitors, which in magnesium, citrate, and pyrophosphate, they all involve stone. The third is mass precipitation, or also called as intranasonic alkalosis, in which the distal tubule and connecting ducts come plugged with crystals, allowing further stone. The fixed particle theory, Alexander Randall noted submucosal plaques on the tips of the papilla. These plaques were formed crystals which remain beneath the epithelium or retained within the cell. The Carr's theory, which states that calculi are formed in obstructed lymphatics and then they rupture in the digestive concept of the calyx and may lose small crystal components entering uneventful plastic. These are 8 ions which are very important in the formation of urinary ions, urinary stones. Some of them are promoters, while citrate, magnesium, and sulfate, they are inhibitors of stone formation. We'll one by one look into all these ions. First of all, calcium. So the total plasma which is present in our blood, 50% of that calcium present in our plasma is ionized and is filtered into the glomerulus. 95% of this filtered calcium is reabsorbed by proximal tubules during the ducts, while less than only 2% is excreted. So calcium inside the urine complexes with citrate, phosphate, and sulfate. Increase in non-phosphate and decrease in urinary pH interferes with this compensation and promotes crystal aggregation. Stone formation increases as calcium absorption, GID increases, while diuretics decrease calcium absorption. Oxalates are important precursors. The important precursors of oxalates are glycine and ascorbic acid. It is a waste product of metabolism and relatively insoluble. 10 to 15% of urinary oxalates come from diet. So in our bowel, we have organisms like oxalobacter pathogens, which are usually killed by they produce an enzyme urease, they colonize our intestine and degrade oxalates and degrade the ability of oxalate absorption. So the presence inside your GID is a good thing. because it's degraded oxalates. Once a drop from GIT, oxalate is not further metabolized and is exclusively secreted by the uterus. In presence of calcium within the bowel lumen decreases the uptake of oxalates because it gets complex to it. So, if you want less number of oxalates to get absorbed from the GI, calcium because it gets absorbed with it and stops the absorption of fluids. Acroxyluria may develop patient with bowel disorders, IBDs, or bowel dissection, bowel bypass. So in phosphate, the key component, which is a key component in calcium phosphate and calcium aluminum phosphate stones, the dietary phosphate comes from meat, dairy products, and vegetables. The small amount of phosphate filtered by glomerulus is predominantly reabsorbed in the fluid. Parathyroid hormone inhibits reabsorption. So in hyperparathyroidism, main crystal found in the urine is phosphate in the form of hydroxyapatite, polymorphous calcium phosphate, and carbonate. Then we have uric acid. 90% of filtered uric acid is reabsorbed, while 10% is excreted. The pKa value of uric acid is 5.75, and it is a product of urea values on the side of the pH. When pH value becomes less than this, the unassociated uric acid predominates, which is insoluble and forms stone. When pH value is greater than this, urates predominate, which are soluble. Pure uric acid crystals are really lucid and may not be visible on plain and round films. However, they are visible on non-contrasted images and are suggested and found to have low levels. Some uric acid calculi are particularly radiolite because of associated calcium phosphate. So, if you have a pure uric acid crystal, it will not be seen on a plain normal film. But if it has impregnations of calcium phosphate deposits, then it will be slightly irregular. Then we have defects in urine metabolism, which means that in the hydrogenase deficiency, which increases the level of xanthine and this type of stone formation. Adenine phosphoryl transferase deficiency results in the production of a compound which is fully soluble in urine and causes stone formation. And we have sodium. So sodium is found at higher concentrations in the core of renal cavity. So remember, we said that urinary stone has two components: the crystal component and the lattice component. The crystal component was formed by unification, the crystal development, and aggregation. So this core, the midpoint of urinary stone contains sodium, and there is an important role in initiating the crystal development and aggregation. High sodium causes increased urinary calcium and increased urinary monosodium rates that promote stone formation. Citrate is a good model, and presence of citrate inside the urine decreases the incidence of stone formation. It binds with calcium inside the urine. So hypocitruria is a common metabolic abnormality found in 20 to 60% of small forms. Patients with chronic diarrhea, renal tuberculosis, and those undergoing chronic thyroid therapy have deficiency of citrate and more likely to form stones. Metabolic stimuli which consume citrate. Citrate is basically a byproduct of Krebs cycle, citric acid cycle, and we studied basic sciences. So Krebs cycle happens in every cell organ. So when there is a metabolic stimulus which consumes citrates, that includes intracellular metabolic acidosis due to fasting, hypocalcemia or hypomagnesemia, it reduces its urinary excretion and thus leads to stone formation. Estrogen and alkalosis increase citrate excretion, so people who are ill females are less prone to urinary stones with their highest levels. The magnesium is a major component of true white stones. Dietary magnesium deficiency is associated with an increased incidence of urinary stone formation. The exact mechanism is not known. Whereas the dietary magnesium supplements also don't protect against the stone formation. So it's quite vague to say that magnesium is involved in this type of process. But according to experiments, lack of dietary magnesium is associated with increased calcium oxalate stone formation and calcium oxalate urea. So it is associated with other types of stone formation. Sulfate, they are mainly found in longer urinary proteins like avoidant sulfate and heparin sulfate in complex with calcium and prevent alkali formation. And then there are other glycosaminoglycans which are glycosamine lactates, pyrophosphate, sphingomyelin, the presence of which inside the urine inhibits stone. There is the inhibit, which includes different types of promoters and inhibitors of urolithiasis. The oxalates inside the food comes from glycoxylate, galactose, lactose, methionine, retin, and purines. So all these components are promoters of urolithiasis. Vitamin C is a precursor of oxalates, so it is also a promoter of urolithiasis, whereas it can also inhibit urolithiasis along with other vitamins like vitamin A and B6. And other compounds like heparin, sulfate, all these inhibit urolithiasis. And then there are specific proteins involved in the inhibition of stone formation, which include crystalline inhibitor proteins, osteocontin, tetracalcin, non-horse protein, and ultrasonography. Mediators of inflammatory response, chemoattractant protein is also an inhibitor of urolithiasis, and the compound which affects free radicals. So the promoters of free radicals is potassium oxalate monohydrate, calcium oxalate monohydrate. They promote urolithiasis, whereas the free radical scavenger compounds like mannitol, superoxide dismutase, catalase, they all inhibit urolithiasis. The physical influence like trauma and membrane injury also promote urolithiasis, whereas in our microorganisms, we have already studied oxalate stone formation that oxalotic organisms are involved in inhibition of urolithiasis. Then we have stone varieties. We have calcium calculi generally, and we have non-calcium calculi. Calcium calculi is further subdivided into 6 types, whereas non-calcium calculi includes white calculi, uric acid calculi, cystine calculi, xanthine, and indentate. So we'll go through all of these one by one to see the pathology of stone formation. Calcium calculi are formed due to elevated urinary calcium, of course, uric acid, and oxalate, or a decreased level of urinary sulfate. The urinary triangle stone, also called as nephrocalcinosis, is frequently seen in tubular erythrosis and hyperparathyroidism, and the increase of calcium absorption from bowel in diseases like sarcoidosis, lymphodepletion, hyperparathyroidism, and vitamin D intake. All these diseases promote calcium absorption at the bowel and thus promote the urolithiasis. The bone destroying disease processes like osteolytic lesions and multiple myeloma also increase serum calcium. Dystrophic calcifications also form on necrotic tissue after a renal insult. The first type of calcium stone is soft calcium nephrolithiasis. So as we know, the normal calcium intake per day is 900 to 1000 milligrams per day. 1/3 of which makes it 300 milligrams is absorbed from the spot bowel. About 100 to 150 is utilized, while 150 to 200 milligrams calcium gets excreted in the urine. So if there is increased calcium absorption from the bowel, there is increased load of calcium filtered from the glomerulus. This causes suppression of ETH, decreased urinary absorption of calcium, and causes hypercalcemia. There are 3 types of absorptive hypercalcemia. The type 1 There is increased urinary calcium greater than 150 milligrams per day, even during calcium restricted. So as we already discussed normal urinary calcium excretion is 100 to 150. So when it's slightly increased, 150 to 200, then it's type 1 absorptive hypertension process. The treatment of this type is giving cellulose phosphate at 15 grams orally 3 to 9 doses of meals. It's an effective non-absorbable exchange resin which binds calcium to the gut, preventing a stall absorption. Then we have hydrochlorothiazides, which decrease renal calcium excretion while they increase absorbed calcium deposits in the bone. Eventually, the bone reservoirs are filled and the drugs and the drug hydrochlorothiazide becomes less sweet. In type 2 disease, the dietary is dietary dependent and calcium excretion returns to normal in a calcium restricted diet. So patients should limit dietary calcium intake to almost 400 to 600 milligrams per day instead of 1000 grams. In type 3, it is due to phosphate renal leaks. So remember, phosphate will be getting leaked from the kidneys, and it counts for 5% of your calculi. The decreased serum phosphate leads to an increase in 125 dihydroxypropanol synthesis, which causes an increased absorption of phosphate and calcium from the GIT, and thus increased renal calcium. Orthophosphate is used to inhibit vitamin B synthesis and is taken as 2 milligrams TDS of vitamin best afternoon at night. The second type of calcium calculi are resorptive hypercalciuric urolithiasis. This is mainly due to primary hyperthyroidism. There is eventually increase in urinary phosphorus and decrease in plasma phosphorus, and vice versa for the calcium, because it gets the plasma calcium gets increased and the urinary calcium gets increased. This hypercalcemia limits the concentrating ability of kidney and the kidney's ability to specify urine. Then we have renal-induced hypercalciuric cases. It is due to an intrinsic renal tubular defect to calcium excretion. So excessive urinary calcium excretion results in a relative decrease in serum calcium, because obviously when calcium is excreted from the urine, its concentration will decrease inside the serum, which will lead to a secondary rise in PTS levels. PTS levels are the paracetamol hormone increase the serum calcium. So in this case, it would be secondary decrease. This mobilized calcium from bones and increased calcium uptake to the GI. This further delivers a large calcium quantity for the kidneys, causing hypercalcemia. It can be confirmed by increased PTS, increased fasting urinary calcium, and normal serum calcium. In such type of disease, the PTS would be raised, the fasting urinary calcium would be raised, and the serum calcium would be normal. It's treated by hydrochlorothiazide, which have beautiful long-term effect, which decrease the blood volume and stimulate cross-tubular and tubular absorption of calcium. And to see if patient has primary or secondary hyperparathyroidism, this type of urinary stones disease, you have to prescribe this hydrochlorothiazide therapy 3 milligrams for 7 to 10 days. If the PTH levels return to normal, then it is a secondary rise, and if the PTH levels are still raised, then it's primary hyperparathyroidism. Then we have hyperuricosuric acid cases. It occurs due to excessive dietary intake of fuels or increase in the endogenous uric acid production. Both situations increase urinary monosodium urates, which absorb stone inhibitors and facilitate and excretion. The urinary pH in this case would be greater than 5.5. It's treated with allopurinol, which is a brand inhibitor. It reduces uric acid synthesis as well as promotes concentration. Potassium citrate is also associated with hypercentration, because we've already seen that 20 to 60% of small formers are hypocyclic, so that was very possible. Hyperoxaluria calcium through Retrograde, it is due to increased urinary oxidative levels greater than 40 milligrams per day. More frequently in patients of inflammatory bowel disease and other chronic diarrheic states that result in severe decapitation that has rapidly transplant. For primary hyperoxaluria, it is a rare hereditary disease associated with calcium oxalate, hypocalcemia, Urolithiasis, and other distal deposits of oxalates. So we will have stones, oxalate stones in the renal parenchyma. We will have calcium oxalate, renal calculi, other places inside the urinary system, and we will have distal deposits inside the oxalates. As well as we like. Hypocytic calcium Urolithiasis. So when there is increased demand of mitochondria of proximal renal tubular cells, as nowadays there is no fasting, so we have this oxidative stress on the mitochondria of proximal renal tubular cells. It occurs in fasting, intracellular metabolic acidosis, hyperkalemia, acid therapy, hypomagnesemia, effect of androgens, state of gluconeogenesis, and when we take an SIUT. There is increased excretion of citrate. All these one of these situations decrease the excretion of citrate inside the urine. Citrate is also consumed by urinary bacteria and UTI. Citrate decreases agglomeration, spontaneous nucleation, and crystal growth of calcium. It's commonly associated with renal tubular acidosis type 1, pathologic therapy, and chronic type 2. Treatment is potassium citrate, 20 to 30 milligrams daily over days. Now we have non-calcium stones, which include steroid stones. Steroid stones are also called NAP stones, because they contain magnesium, ammonium, and phosphates as well. They are associated with urea splitting organisms, including Proteus, Providentia, Vegeta, Staphylococcus, and Mycoplasma. And the high ammonium concentration makes the urinary pH alkaline, that is greater than 7.19. So it's important to. So steroid stones are highly infectious stone, which includes all these organisms which split the urea, produce ammonia, and make the urine alkaline. Frequently presented as renal stack or calculi, and they are treated with acetohydroxamic acid, which inhibits the action of epithelial pH, reducing urinary pH and decreasing the likelihood of precipitation. And we have another non-calcium stone, which is cystine stone. This is due to an inborn error of metabolism. It is autosomal, it is inherited in an autosomal recessive fashion, which there is abnormal intestinal mucosal and renal tubular absorption of diabasic amino acids like cysteine, ornithine, lysine, and arginine. All these are diabasic amino acids which gets absorbed inside your bowel and inside your body. The radiographic appearance of stone is faintly opaque, ground glass, and smooth edge, while urine analysis reads ectopic crystals. Stones are amber colored and they have high recurrence rates. So, minimally invasive surgical techniques of terminal vertical we don't have to do rigorous surgical procedures on them because they'll recur again and again. It will be a problem. So, we have to go minimally on your surgical technique. The normal cystine levels inside the urine is less than 40 milligrams per day. If the patient is heterozygous cystinotic, it will be 150 milligrams cystine, and if he is a homozygous cystinotic, it will even increase greater than 50 milligrams of cystine per day. It's treated with high fluid intake, more than 3 liters per day, urinary alkalization by keeping pH more than 7.5, and it can be monitored by the patient himself at home by an atrazine indicator paper. And penicillamine and the captoprofene antacids get reduced urinary And we have xanthine stones, which are secondary to a congenital deficiency of xanthine dehydrogenase, which normally catalyze the oxidation of hydrogen to xanthine and xanthine uric acid. Stones are really useful and damage yellow color. Intravenous stones, so intravenous is a protease inhibitor, a drug which is given to patients of AIDS. So 6% of patients prescribed with this medicine also they develop stones. They are the only stones to be ready to send on non-contrastive scans, so that you won't be able to see them on a CT scan well. And then we have other types of stones. Silicate stones, some patients are using, they have long-term use of antacids which contain silica. So these patients are also prone to urinary stones. And then we have medicines like hydrochloride, diazides, which have triantine with it. So these triantine stones are associated with antihypertensive medication and are really used.
Excellent. So these just a minute so that we can just recap, because it has been too exhaustive. But this is yes, but this is very interesting. Interesting in the sense that this is a summary. Even that it is exhaustive. It is a summary. It is a summary and an excellent summary of the whole topic of urolithiasis, and it makes you understand that it is something which is multifactorial, and there is a very wide room for improvement in services. I'm talking about from the angle of running a clinic, for instance, that we have in our institute also, and that is a stone clinic on every Monday. But mostly the stone clinics are slightly geared towards a thing called damage control. For instance, if you have got a stone, then you have to just take it out, just remove it, no matter how it came about, or what is the actual pathogenesis behind it. It is something of a secondary value. Primarily what patient needs is something of a relief from the presence of a stone causing obstruction to the kidney function, obstruction to urine, causing kidney to swell up, hydronephrotic kidney. Patient has got a lot of pain. Plus, it might be there might be a result of this process into obstructive nephropathy, and there is an increment in serum creatinine and urea. So what we are actually doing in our clinics, in our day-to-day life, is to deal with the stones as such. We want them to be removed as quickly as possible, as efficiently as it has to be, so that there is less morbidity and the patient should go home as early as possible. For instance, if that can be done through lithotripsy and the stone is small enough, then it is very good, because patient doesn't need any anesthesia and there is minimal analgesia which is required. Apart from that, if that is not possible, the stone is of a bigger size, then you might go on towards PCNL, and there are many techniques which are actually modifications of the standard PCNL. You call them micro PCNL or mini PCNL. You go on decreasing the diameter of your axis and the instruments, miniaturizing them so that there is again less morbidity and patient should be up and about in very say less amount of time. But the bigger challenge in dealing with urolithiasis is something of metabolic in nature. So if you are interested in the evolutionary process behind stone formation, then there lies the actual challenge. And the actual challenge is something which mostly doesn't attract the attention of a urologist. of a surgeon, for instance. But as rightly explained by our colleague, Dr. Shersha, we have got a lot of ground to work on. We have got a lot of thinking to be done in order to not only preempt something called Staghorn calculus, when the whole cast of urinary pelvis and calyx has been formed in the form of a stone. But before that, if we can just pinpoint the metabolic process going on behind the formation of a Staghorn calculus, then we might be able to either preempt the formation of a Staghorn calculus, or once it has been done and taken out through surgery, we can always do something called follow-up for these patients, and then the recurrent stone formation will not be there. So again, coming back to the same point, that there is a lot of a lot of areas to be explored and a lot of work to be done in case of properly running a service regarding urolithiasis. Yes, please continue.
So now we'll discuss some of the science of renal colic. So renal colic is not like the intestinal or biliary colic pains which comes and goes, wax and wanes, but renal colic may be relatively constant. The stone burden doesn't always correspond to the severity of stones, as we have discussed. The Staghorn calculus is a big stone, and it can cause this dull ache, say, on your back. While ureteric stones are very small, a few millimeters, but they're very painful. So ureteric pain is referred to the areas of distribution of the inguinal nerve and then branch of the nerve. The calyceal calculi can occasionally result in spontaneous perforation with urinoma, fistula, or abscess. The pelvic-ureteric junction stone can cause pain in the costovertebral angle and often testes, because the nerve supply of skin and testes are the same. Pain of mid-ureteral stone is more localized toward the lower abdominal compartment. Stone in intramural ureter may mimic cystitis, urethritis, or prostatitis by causing suprapubic pain, urinary frequency, urgency, dysuria, sprinuria, or loss. Patients with bladder stone present with irritative body symptoms, intermittent urinary stream, urinary tract infections, hematuria, or pelvic pain. Prostatic stones are tannish gray color, may be associated with chronic prostatitis, and mostly composed of calcium phosphate, and surgeons mostly come across these types of stones while doing their. Seminal vesical stones are smooth, hard, and very bare. They may be associated with hernia. Urethral stones are mostly in the prostatic or pelvic part and may present as urinary retention. We can have gross or microscopic hematuria. We can have infections. Now, as we already discussed, stool or lab stones and the calcium phosphate stones, they both are the infectious stones. In pyelonephrosis, the renal urine aspiration is the only way to make definite diagnosis, as bladder urine cultures pyelonephrosis are negative. So while if you are doing PCN for pyelonephrosis and you see there's pus, so you should abort the procedure. You should do appropriate drainage and treat with appropriate antibiotics. If you are not able to recognize this pyelonephrotic process, then it may develop into very dangerous fistula. You can also have fever, nausea, and vomiting. While evaluating for the renal polyp, you have to keep in mind all these diseases as well during your surgery. And you should know all the examinations and all the investigations that you need to perform to exclude all these diseases. The first of which is acute appendicitis, ectopic and unrecognized pregnancies, ovarian pathologic conditions like twisted ovarian cyst, bowel obstruction, biliary stone with or without obstruction, peptic ulcer disease, acute renal artery embolism, abdominal aortic aneurysm, or related numbers. In history, you have asked the nature, onset, connected radiation, and activities that exacerbate or reduce pain associated nausea and vomiting, gross hematuria, lower urinary tract symptoms like dysuria, urticaria, and severe burning fish, and so these are some of the risk factors for which you also have to evaluate the patient. The first of which is Christianuria, socioeconomic factors, diet, occupation, climate, family history, and medication. So the urolithiasis is more common in cases of rich people and industrialized foods, and increase in animal protein, sugar, and sodium intake increases the incidence of stone formation, high dietary fiber, vegetable protein, and unrefined carbohydrate intake increase the incidence of stone formation. The physicians and other white-collar workers have an increased risk of stone formation as compared with annual labor visits involved with physical activity as well. People in hotter climates are more prone to dehydration and thus increased stone formation. Black people are less stone formed by flying, and the black African American they have less incidence of stone formation. We have to ask about family history, and then of course medications, as we have already discussed, dialysis containing thymidine, the antacids containing SIUT, the protease inhibitors like Biliary, Untitled Chapter, and they are all involved in stone formation. While examining a patient with acute urology, you have to see the patient's position, because the patient with the renal colic will tend to find these multiple bizarre conditions. As compared to the patient with peritonitis, the patient with peritonitis will still not grow, but the patient with renal colic will tell about inside the bed. You'll have tachycardia, sweating, osteovertical angiogenesis can be present, and abdominal palpable mass can be present because a long-standing obstructed kidney can be hypertrophic, may have increased inside the size. If you see fever, hypertension, cutaneous dilation, they are all signs of flu sepsis, which require intervention in the form of heavy antibiotics. The radiologic investigation include the tomography scans, intravenous pyelography, tomography, AUV films, and detected ultrasonography, retrograde pyelography, magnetic resonance imaging, and Scintigraphy. So coming to the treatment, the ureteral calculi, the calculi inside the ureter, 4 to 5 millimeter size have 50% chance of spontaneous passage. Calculi greater than 6 millimeter have slightly greater than 50% chance of passage spontaneously. Then we have medical expulsive therapy, med therapy, which includes the use of antibiotics, NSAIDs with or without those steroids, which also facilitates spontaneous ureteral stone passage. And generally, if we say the proximal ureteral stone has a 10% chance of spontaneous passage, the mid-ureteral stone has 25% chance, while the distal ureteral stone has 50% chance of spontaneous passage. While evaluating soluble stones, you have to go for these investigations, in which you do a baseline sealing evaluation for black urea nitrogen, urea, retinine, calcium, parathormone, phosphorus, and uric acid. You do a stone analysis, and 24 are urine samples for all these individuals. And then we have alkalinizing pH agents, which include potassium citrate, 60 milligrams in 3 to 4 divided doses daily. Alkalinizing agents can be used on almost all urinary stones, so this is your drug of choice. Gastrointestinal absorption inhibitors include cellulose phosphate, 5 grams, 3 times daily, followed by magnesium supplementation 1 hour after cellulose phosphate course. So if you remember, this is cellulose phosphate is given absorptive hypercalcemic cases. The The phosphate supplementation includes 250 milligram formulations 3 to 4 times a day. Diuretics include the thiazide diuretics starting with 25 milligrams daily. Calcium supplementation for indirect hyperoxaluria, calcium and urolithiasis. You are more prone to develop oxalate stones, then you will give patient calcium supplements because it will bind with oxalates inside your bowel and decrease its absorption. Uric acid lowering medicine include allopurinol 300 milligrams per day as starting dose, and we have 2 years inhibitor, acetohydroxamic acid 50 milligrams, that 50 milligram tablet 3 to 4 times a day. And for prevention of skin calculi, we have to do massive food intake, urinary organization, and relation with penicillin and mercaptan for renal test. So, any questions?
Right. So the forum is open for any question, any clarification.
Sir, I have a question.
Yes, please.
Sir, in a slide you mentioned that promoters of urolithiasis and inhibitor of urolithiasis and vitamin C was mentioned in both places.
Mm-hmm.
So how we could see that vitamin C is now promoting or inhibiting the urolithiasis?
Yes, you go back to the slide, please, Trisha. Yes, you see, there are two things. One is how this vitamin C is being used. For instance, if it is used uh, as a dietary component, then it can be a precursor for oxalate because it has been absorbed into the circulation through the gut. But the same thing can also be taken in another way. For instance, if vitamin C as part of oxalate diet is there, then it will rather be um, a scavenger than just a precursor. So it depends how this vitamin C is being used, whether it's a supplement or it is just an accompaniment. Now, you can talk about the semantics. For instance, maybe these are just two words, but they are not words. Vitamin C component as part of the diet has to be at a minimum level, a level which is needed. Now, if it is beyond, if it is just below that level, it will be there in the body, but it will not be acting as something which is a scavenger or an inhibitor of crystalline aggregation. So you see, there is a fine balance. You have to use it uh, as part of something. So it should be a part of diet rather than just a supplement.
Okay.
We'll see about this thing later also. Yes, yes, please.
So what is the role of MRI in the diagnosis of stones? Do you MRI for renal stones?
You see, there are certain things which have been proposed by a lot of people through their own special interest into the areas in which they are working. But there is a thing which is called guideline. You know, guidelines are guidelines, and they have to be followed as such. You have to adjust yourself and put yourself into guideline because there are certain things which might be cost effective according to your setting in which you are working. So whenever you want to image the location and the presence of a stone, for all practical purposes, it can be done through a non-contrast CT scan. Now, again, the question is, what do you want to see? You want to see whether the stone is present or not, and also you want to exactly know how much is the density of the stone, and that can be picked up through Hounsfield units on a non-contrast CT. So in many of the cases, even the contrast study is not needed. But you might also think of something, for instance, presence of stone and presence of PUJO. Now, if you want to study the uh, functioning aspect of the kidney also, then you have to have a contrast study. So the same goes with MRI, for instance. Now, MRI is something which is sometimes advocated for those cases where I think in females in later part of gestation, but that is without gadolinium. So everything has to be judged according to the condition in which it has to be done. Uh, it is not something which is practical in the sense that it carries with it a lot of cost. MRI. Now you have to have cost-effective phenomena in your daily, day-to-day practice. Otherwise, it will be too hard for anybody to, or any system to bear that kind of a burden. So MRI, yes, it has got a lot of plus points because it gives you a very good resolution of a lot of structures. For instance, if there is kind of a situation in which you want to have differentiation between the presence or absence of an adipose tissue, then MRI is much helpful as compared to CT scan. Similarly, if you want to image something in the pelvis, MRI has got an upper hand as compared to CT scan. So it can be tilted towards one side or the other, depending in which case scenario you want to use which kind of imaging technique. If Fazan, you want to say something?
Thank you.
So, I just want to say once in research form, I remember Adib Saab said that there is a vast prevalence of stone. There is no limit of climate, even in the most wet areas and the most dry areas of the world. So, can you enlighten us about this climate change? What I remember is Adib said that the dehydration, this can be, but it's not the absolute thing.
Yes. There was one, not an experiment, but an impression. There was a doctor who was actually an Anglo-Indian who was working in this province of Sindh and particularly in the region of Tharparkar, probably Cholistan also. I don't particularly remember his name. Probably his name was Dr. Pedro. What his actual impression was, he was interested in stone prevalence and the dietary effect and the effect of temperature also. What he saw was in the month of Ramadan, for instance, in which we are actually, the incidence of stone disease and renal colic goes down. This is very interesting. Now, people used to drink little water, no water at all. I think if you take the 24-hour volume consumption during the month of Ramadan, it becomes less as compared to normal days, because for 14 hours you are without anything, no diet, nothing of the sort, no water at all. So if you happen to be in, for instance, in Punjab or Sindh in the month of June, for instance, and you happen to be in the month of Ramadan, then you can very well expect that your urine would be highly concentrated, very close to iftar, perhaps. But what he saw was slightly different. He also saw that yes, maybe the quantity or the volume of urine is low, but the volume of or the ratio of solutes as compared to solvent is also decreasing. So as such, the incidence of stone is decreased because the protein consumption is also decreased in the same instance. So his observation was quite interesting. So if I want to place your question in the light of that kind of impression, we can always say that it is multifactorial. There are many facets of the same disease. There might be low amount of fluid intake, there might be high protein consumption, there might be high calcium availability. There are metabolic diseases, as we have talked about. But above all, what is more important is something which is a genotype and a phenotype. What I'm alluding to now is something which is which is of interest to those who want to study all disease aspects, not only this urolithiasis, but also something which is, for instance, immune reactivity to coronavirus. It is all because of our own phenotype. We are different, and every other geographical area is also different because of many influences on the genetic expression of certain important things that we call the phenotypic expression. So the population that resides in this area has got probably a different kind of a phenotype, and that leads to more stone formation as compared to any other area in the world. The highest incidence of stones is probably in this Rajasthan, Cholistan, and Tharparkar area, and you can very well see that all these staghorn calculi, they are there in much greater magnitude as compared to the West. In the West, they don't see such things as a staghorn calculi, or they see less. We see a lot. In any day on a Monday, you can see a lot of cases that a person in Europe can see in 1 year. So that is something which is of interest. But again, the main thing is maybe beyond phenotypic expression, the homeostasis is what that is required. Homeostasis means there has to be a balance. There has to be a balance between solute and solvent. There has to be a balance between the dietary intake of calcium, proteins, and something called, citrates. So if your diet contains a lot of things which are inhibitory, which have got inhibitory effect on crystal aggregation, then you will have less incidence of stone formation. For instance, if you go to south of India, they have got one thing which is very common in their diet, which is not that common in our diet, and that is tamarind. Now, what they say that tamarind is something which has got a very high quantity of certain good things which are inhibitory to stone formation. Similarly, their diet is also very high in turmeric. Now, turmeric is something which they say, and probably it is true also, it is when it is consumed in a probably bigger quantity, it is protective towards some neurological diseases like Parkinsonism. So there are plus points in diets and there are certain negative points in diets. They differ from one area to the other. It's an interesting subject.
Yes. So then one more thing, I wonder when we were doing OPDs, we used to set the stone for the stone analysis, and we know that these could be the calcium oxalate or fluoride. Then why every patient will send the stone for the analysis? What is the reason behind it?
Two reasons. One is there is always someone who is doing his research, a research paper. So maybe the stones were going there in a larger bank of data collection. The second thing is we always want to decipher what is the actual identity of the stone that has been taken out. Yes, that can be judged through many things. For instance, the Hounsfield unit on a CT scan, by the shape of the stone, and by the reaction of the stone to any energy source that has been applied over it. through PCNL or ESWL. You can always have a vague idea what kind of a stone is this, but in order to judge whether you want to prescribe something for the follow-up of this patient or not, you need to know exactly what is the composition of numerous constituents within a stone. It is not one thing. Nucleus may be different from something on the periphery. So you need to know what is the nidus. You also need to know what is on the periphery making the stone, so that you will be able again to do something for future. Yes, Hamza. Sorry.
As said, Dr. Shah, the estrogen pathway have a role for stone formation.
Yes.
But still, male have more chance to develop stone as compared to female.
Yes. Shesha, what do you say about it?
Because females have no estrogen and males do not have estrogen.
No. So how come this estrogen is protective or it is non-protective? What does it do? So we don't know. Right. So we have to look for it. Yes. We have to look for it, but you see, there are many things which are attached to this this hormone, estrogen, and these are very interesting. For instance, if there is a less amount of estrogen in a female, the mucosal surfaces are dry. So why is it so? Because it carries a lot of water with it. So if you have got a person who has got menopause and there is low estrogen, so that patient will be asking you for to do something for retention of urine, perhaps, just because of the reason that the urethra is parchment-like. It is dry as a bone or as a leather. So it acts just like a stricture. It is not a stricture. It is a dry senile urethritis, and that dry senile urethritis is just because of the reason that estrogen is not there. So if you supplement estrogen, you do something called, prescribe something called estrogen pessaries in those patients, their mucosal surfaces become wet. And when they become wet, then the senile vaginitis and senile urethritis goes away. So it has got some important physiological function to be done that is attached to estrogen. So probably that is one, might be a cause why stones are less as compared to males, where the stone incidence is more as compared to females.
Right.
Right, Jay. So any other point? Right. So what I have posted today, as you can see on your WhatsApp group, is the 2020 edition of EAU guidelines. So I don't know whether you already have it or not, but this is one thing that you can download and maybe print. So this is just a PDF format of EAU guidelines 2020, this year's. The second thing is we have another lecture tomorrow and then on Saturday also. And then for round 2, are you ready for round 2 from Monday, or do you want something in between, some days off? So that would be again, it's all right. So Rafe, are you ready for Monday?
Yes, sir, I am ready.
Okay, very good, excellent. So we'll start a second round from Monday also, and I've suggested yesterday that if you want to, then you all can be included in the online discussions or presentations which are going on here at SIUT in Karachi, which are followed by MCQ tests. These are tests which are online tests, so there is nothing called pass and fail. So would you like to be included?
Yes, sir. We also discussed this yesterday. We were already happy to.
Okay, so it would be an interesting sort of thing because you can have a lot of time in your home, and you can always listen and see these presentations on our channel, the SIUT YouTube channel, and it will be very easy and interesting. So I'll include all your contact numbers into that group, and that is known as SIUT PG online group. So then you all be with us.
Okay, sir.
Right? And we are working on your question, and that question was about your result. Right? So you will soon hear something from myself or somebody else about it very soon. Right? And the third thing is, I think everything would be settled, inshallah, in days to come. And we'll be expecting you to join us probably from 1st of June, inshallah.
Inshallah.
And because I think the railways is also opening, maybe the flights are also open. And yes, we have got a very nasty hit of coronavirus, but this is the life, and I think we have to be with it. Right, sir? Right. Okay. So thank you very much. Meet you tomorrow. Hafiz.